babies and healthy lifestyles for families. It protects against hazards at work, at home, and in the environment. And it prepares for and responds to disease outbreaks and other public health emergencies. If you're thinking it's a big job, you're absolutely right. Now that you know what public health is, you'll understand how lucky you are to live in Idaho. Idaho public health districts reach every corner of the state. Their excellence is recognized by the National Association of County and City Health Officials. In 1970, Idaho's legislature recognized the value a formal public health structure would provide Idaho residents. That year, the legislature created 7 health districts to ensure that all Idahoans have access to local public health services. Each district covers a group of counties. The health districts share a common vision: healthy people in healthy communities. They focus on local needs, but their ultimate goals are the same: to prevent disease, promote healthy lifestyles, and protect the health and quality of the environment. Local management is important to understanding local needs, so the legislature made it clear that the state's public health services will stay locally controlled and governed. County commissioners in each health district appoint a board of health that governs the district's policies based on its unique local needs. For example, all 7 districts offer immunizations, but only a few offer nursing services in local schools. The health districts aren't state agencies. They're single-purpose districts, like school and highway districts, with a specific job: to protect the public's health. Each district is accountable to its Board of Health. Funding for the health districts was a puzzle, but legislators zeroed in on a logical plan. To solve the puzzle, the state entered into a partnership with its counties to provide basic operating funding to the 7 health districts. Other revenue sources include fees from clients and grants and contracts with federal and state agencies. The legislature approves only the state's portion of funding that goes to health districts. The counties within each health district are responsible for setting and approving their district's overall budget. It was quite a feat creating Idaho's excellent public health structure, and state residents just like you have benefited ever since. Idaho Code outlines basic services health districts are expected to provide. These services vary by district according to local needs, but generally fall into 5 broad areas. Have you ever gotten sick after dining out or playing in a public pool? Idaho public health districts are the public's front line of defense against infectious disease outbreaks. Idaho keeps a list of more than 70 infectious diseases that are reportable to the health districts. Once an incident is reported, public health epidemiologists, the disease detectives, start to investigate. These diseases keep public health investigators busy year-round. They investigate the source of illnesses like tuberculosis or salmonella, and educate the community on how to protect itself from the exposure and spread of diseases. Health districts share the information gathered in disease investigations directly with state and federal agencies, as well as with local medical facilities and infection control practitioners. Have you taken a smoking cessation or senior fitness class through your local health district? Public health educators actively recruit students to improve their health. They work with teens, adults, and pregnant women to discourage tobacco use. They also offer tobacco cessation programs. These educators teach clients to prevent and control chronic diseases such as asthma and, for some, cancer. In the United States, falls are the leading cause of injury deaths among older adults. Idaho has so much to admire. Ask any resident, and they'll talk about the Panhandle's lakes and mountains, the capital city in the south, or the spectacular beauty of the Sawtooths. Idaho residents refer to their state as paradise, and for more reasons than the inspiring landscapes. Idaho offers an unbeatable quality of life, good jobs, a reasonable cost of living, and an excellent, yes, excellent system of public health districts. Public health makes a difference in the lives of all Idahoans every day. No wonder other states admire and try to learn from Idaho's public health districts. Wait a minute. You're not sure just exactly what public health is? You're not alone. If you're like most people, you know public health is important in your life, but you're not quite sure how and where it fits. You deserve to understand the full story of anything that plays such an important role in your life. Let's start with the basics. Public health is the practice of protecting, maintaining, and improving the health of communities. Public health defends you from any health threat, regardless of the source, and works tirelessly to prevent disease outbreaks. Have you wondered why epidemics are so few and far between? It's because public health's priority is to stop the spread of disease and the discomfort, disability, and premature death often associated with it. For example, public health has
Because all these other, but that's what.
Alrighty, so we are about 6 minutes past the top of the hour. If everybody's ready, I will go through a few notes before we get started.
We're ready to start the meeting now. Ashley, just 1 minute, please.
Yeah, you got
Okay.
It's not critical to me.
Yeah.
We are Republic form of state where we represent. Don't take a vote on my property.
Yeah.
So you gotta use your.
I thought we might get more, yes,
Just
no, but
that's what everybody wants us
governor,
to do it.
no.
No, you gotta do a little bit of both.
When the board members are ready, we're ready to begin the meeting. I mean.
Okay.
All right. Morning. Morning, everybody.
This is our sign-in for those who wish to make public comment this morning.
Okay.
I got a trailer, I think I'm gonna come up and park it in council, but that's all right.
All right.
For like 3 months out of the year. That's okay, isn't it?
Yeah, I don't see a problem with it.
All right.
I'd go for 4, Tom.
4 months out.
Yeah.
There's a new fancy RV park going in. There's a new fancy RV park going in. This guy's doing a fantastic job.
Okay.
Right off of Highway 95.
All right, we're late getting started. I was late getting here. Got held up in that crash 'em up down there on 2026. And so I said, well, I'll get around that. So I turned around and went back, and every road I went to was closed.
Yeah, detour.
I mean, my goodness. I thought I was gonna have to go out here to Wilder or something and come around finally, but I did make it finally. Anyway, we need to get started here. So I will call the meeting to order. Would you join us in the pledge? I'm gonna ask Commissioner Hannigan to lead us in that.
Pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you. The agenda says I need to have a roll call, so I can see most everybody that's here. Who's here? Everybody's here except Nate. Is that all?
Yeah.
Nate, are you with us?
You up there?
Yes, I am.
There you go. Okay, I think we've got everybody here again today. Appreciate that. Is there any other items informationally that somebody'd like to put on the agenda?
Mr.
Yes,
Chairman,
ma'am?
can we add executive council update under the director's report, which is informational?
Under the executive, now say that again here.
Executive council update under the director's.
Executive council update.
Yeah.
Okay, that has been proposed to be added to the agenda.
I make a motion, we accept
Okay?
that agenda amendment.
Okay. I have a motion and a second. All in favor, say aye.
Aye.
And I should have asked whether the rest of the agenda is satisfactory. Do it all in one.
We can just do it one leg at a time.
Okay, well,
How you put your pants on it.
yeah, it's a way, well, I have to sit down sometimes. I can't even stand up from that. Anyway, okay, we need an approval of the agenda. Is there anything else that needs added or changed?
I'll move with the approved agenda.
Okay, have a motion, a second? A motion and a second. All in favor, say aye.
Aye.
Motion carries. Okay, we are at time for public comments. We have a sign-in sheet. I have 1, 2, 3, 4, 5 folks who have signed in, and we have 15 minutes available on the agenda. So I guess those who will speak, please be succinct, and we'll start with Maggie Goff.
Happy Tuesday. If you'll please indulge me, I just wanted to do a quick recap. So March 2020, we were given the news, especially in Idaho, that there's this deadly coronavirus that's going to kill tens and tens of millions of people. By May 2020, some of the models had proven to be incorrect, and different scientists and doctors that were outside of the internal part providing information that somewhat conflict. By July, there are definitely two distinct camps. People that their science leads them one direction, and the science that leads them another direction. And I also noticed that we stopped talking about the coronavirus. Instead, we start changing the wording of COVID-19. It seems that some districts chose to, at that time, there was information on both sides, a lot of information on both sides, and some districts chose to look at all of it, while other districts chose to just stay with one narrative. And now here we are in October, and the camps are just very, very divided, and we have faces like Fauci and Sanjay, Dr. Fauci and Dr. Sanjay Gupta, and then we have the White Coast Summit and the Dr. Scott Atlas, and it seems to me that they've stopped giving the numbers of deaths for COVID-19, and now we have just shifted to testing positive. And so there seems to be, and I'm not going to apply motive, but there seems to be an agenda that continues, and while we should be pulling back in a lot of counties and a lot of health districts and a lot of states have been pulling back, there are still some that are ramping up. Just last week, 2 people were arrested for not wearing masks. And I just want to end by saying thank you to this board. We've noticed early on that while many were mandating, we recommended, and while many have been blocking us out of the meetings, you provide an external door to allow us in. You have not been cutting yourself off from us. And I know you've been receiving pressure, which is why we just really appreciate you choosing liberty and appreciate everything that all of these other functions have done. Let's give them a round of applause.
All right, thank you. Carol Andrews.
Carol Andrews has allowed me to thank you. I want to express her gratitude, admiration, and courage for your unity, for our liberty. She let me speak because we have to have an sign up to speak, and I didn't do that. So I just wanted to say I'm sorry, Jurgen from Canyon County. I also want to thank you for standing against the bullying of federal and state government. I had trouble getting here. I don't know if you guys know how difficult it is to get your sheep fed and your husband off to work and get in the dark and get yourself together and think of something to speak by 9 o'clock in the morning. Anyway, I just want to remind executive agency that the state constitution sets up city county commissioners to be elected by the people and accountable to their respective counties. That way, they have some control. Southwest District is an executive agency, not a legislative body. The Board of Commissioners in the county is a legislative body. Southwest District is an executive body and is acting in this as this board meeting as a legislative body. You make regulations that have criminal penalties for people who do not have any say in their decisions. For example, trespassing. We know that we all saw that there were 2 people arrested at the Central District House last week for not wearing masks. These are law-abiding citizens that were arrested and charged with criminal penalties. For regional, the regional health district cannot make law. Only legislative branch can make law in our Republican form of government. So I just want to remind you, furthermore, the state constitution does not recognize regional government. Just concerning that, I just want to point out, I think we all saw the footage of the Owyhee policemen speaking to people who were outside the central district and people that they ended up arresting. And one of them kept moving his mask, which was right by his nose. His fingers kept going by his mask, where his nose was, up and down, because when you're speaking, the mask goes down, you constantly have to touch it and pull it up. Who is more likely to be contaminating things like the doors zooming in and out than the people, the law-abiding citizens standing there who didn't have any masks on, who probably didn't touch their faces for hours? Is this really, concerning masks, is this really about public safety? I just want to point out real quickly that I was denied medical care yesterday because I went to see my dermatologist and they required masks, and I don't wear masks. And I was denied medical care. Every day, my hip hurts when I walk. Everything I do, all my stores. But if I go and have my hip surgery, which I need very badly, I'll have to wear a mask, so I'm putting it off. That's just not right. So my last comment and question to you is the mask mandate really about public safety, or is it about public control? Thank you for that insight.
Thank you. All right, the next person I have is Sydney Alex, is that right?
Hello, my name is Sydney, and I am a resident of Washington County. Thank you for having this meeting. I have come before you today to express my concerns regarding the extreme measures taken during this pandemic. The response to COVID-19 by the Southwest Health District and also our state government has greatly concerned me. Both seem to believe that lockdown, social distancing, and masks will help stop the spread of the virus when actually there is factual information proving otherwise. At the end of August of this year, the CDC updated their numbers showing that only 6%, or 9,210 of the recorded 153,504 deaths actually died from COVID-19. Did you know that coronavirus, or SARS-CoV-2, has failed cautious postulates, namely in that it has not been isolated or thoroughly proven to be causing this disease? This fact has been admitted in a study published by the New England Journal of Medicine. Lockdowns have been shown by both the Lancet Journal of Medicine and the World Health Organization to be ineffective, and that they have not helped to slow the spread of the virus and instead have devastated the lives of many people in a variety of different ways. Did you know that the CDC has recently shown that 85% of coronavirus patients reported to have been wearing masks always or often? Not only that, but masks have been shown to create a condition called hypoxia, or reduction of blood oxygen levels, which increases the risk of stroke and heart attack and promotes inflammation, which encourages the growth and spread of cancer. My grandmother is a resident of Canyon County and resides in an assisted living facility which has been forced to follow the coronavirus recommendations from the Southwest District Board of Health, and the facility where she's at, they've been threatened with withdrawal of their license if they do not follow these recommendations. During this pandemic, I've watched my grandmother sink into a state of depression at the long separation from her family. She has become so frail and worn, living out monotonous days all alone. One of the nurses at her facility told my mom that she has watched the elderly die of loneliness, and that many have expressed that they would rather die from the coronavirus than remain separated from their families and die alone. These pandemic restrictions are wreaking havoc on the lives of so many. Businesses have been destroyed, suicide rates are skyrocketing, and the elderly are dying of loneliness. This cannot go on any longer, or the damage will be irreparable. Thank you.
Okay, thank you. Mary Kay?
I'm Mary Kay, and I'm his mom. So my voice in terms of my mom, she's part of their generation, and she lost so much.
Speak up.
Yes, that's what spurred me to come out here today. I do
say thank you that you have to take the course together and I hope that you sincerely. But I feel like we've been conditioned to things to come.
I can't hear you.
Can't hear you. This is America. We're being trained to thank you. I don't want to wear masks we're not going to the next level. So I mean that with all due respect. Dr. Rainer Fuller is one of the 4 founding members of the German Corona Extraparliamentary Inquiry on July 10, 2020. According to Fuller, an international class action lawsuit will be filed against those responsible for implementing economically devastating lockdowns around the world, as well as using fraudulent testing to engineer the appearance of a dangerous pandemic. This includes everyone from the local policymakers all the way around the world to the World Health Organization, drug companies, and essentially this country will be following suit. This kind of crisis, according to all we know today, must be these days, it is probably the greatest crime against humanity. The lawsuit going on, worldwide contact scientists around the world, and among the questions this maybe seeks to answer is, one of them, is there a COVID-19 pandemic, or is there only a PCR test pandemic? Do pandemic response measures such as lockdowns, masks, mandates, social distancing, quarantine regulations serve to protect the world's population from COVID-19, or do these measures only serve people? And cause people panic? Here is a powerful motivator. I never got to kids outside in the mouth. So Dr. Martinez, he's former vice president of Pfizer Pharmaceutical Company, briefly went on record stating there is no science to suggest a second wave should happen, and that false positive tests result from unreliable PCR tests that are being used to manufacture second wave cases. And we found online. To clarify, COVID-19 is a dangerous disease, just like the seasonal flu is a dangerous disease. And of course, COVID-19, just like the seasonal flu, may sometimes take severe chemical course and will sometimes kill patients, just like the seasonal flu. The PCR test fraud. First of all, the PCR tests have not been approved for diagnostic purposes. In case positive cases, positive cases, shut down the don't let them out of their shell. Its inventor, Mary Phillips, Carrie Wilson, has repeatedly unsuccessfully stressed that this should not be used as an item. As noted, Fullness is the German lead running this, the lawyer. Our teacher is incapable of diagnosing any disease. A positive PCR test result does not mean the infection is present. If someone tests positive, it does not mean they're infected with anything, let alone with a contagious SARS-CoV virus. Even the United States CDC agrees with this. Quote, directly from page 38, one of the publications in Chroma PCR test dated July 20. So to politics, this is the kind of lawyer who's addressing this worldwide, who believes that corrupt people, these facts, are hereby offered as a lifeline that can help you readjust your course of action and start the long overdue public life of this country. And that's what I'm doing with Charlie. Security like numbers and Brianna from St. Louis. It's a fear of God under tyranny and public man. We're not on this planet long. I would fear fellow Americans. Those in the nursing home that are going to Christmas. People taking their lives. Kids that are forever going to be messed up because they're just walking around in the house. Not the Philippines where you're shot in the head, you're looking at. God forbid you take them around. And thank you for your time.
Thank you. Max? What's your last name? Raslin. Okay, thank you.
Good morning.
Morning.
So first off, I'd like to thank you for not complying to the threats that were received. So thank you for that.
Can you speak up a little bit louder?
Yeah.
Thank you.
Thank you. Normally I do speak loud. like to kind of start off with, I guess, an idea. You know, are we increasing our death rate by prolonging this? In my opinion, I think everybody is going to get this virus. I don't, you know, I don't deny that there is a virus. I know that there is a virus. And I feel like with us not being out and being social, it's just extending the length of this virus, and that's going to equate to more deaths. Now, whether that's, you know, these deaths are a high number or not, I don't believe that the numbers are what they are. I believe that, you know, with hospitals being incentivized to well, not really incentivized, but needing to, you know, a regular, let's say, heart attack as a COVID-19 death because they need the money. I don't think that's, I don't know, I think the numbers are skewed, but I think we should be out there interacting with each other. I mean, we all need our, you know, each other's germs to survive. You know, shaking hands, hugging, whatever. I think that's what's going to keep us safe, communicating. I mean, we've been out for months together, and of the, you know, those people that we've been hanging around with, I mean, we've had nothing. So it just doesn't make sense. I think we should just end everything COVID-19 related. I think it's ridiculous what we're doing. But I thank you, though, for at least not the hope. So there was a question by somebody that is not present here. She wanted to ask about FEMA and if it was extended. Sorry about that. I guess it was something about 14 days. There was, I don't know if you know anything about that.
I would have to ask our director.
Okay.
I'm not sure what the question is.
I'm not exactly sure either.
Wondering if the 14-day FEMA contract has gotten extended. Did we actually ever have a FEMA contract?
No.
I don't think
Okay,
so.
so FEMA was never part of this.
At one point, we
There's a,
14 days to get your staff.
They weren't FEMA.
Oh, okay.
That wasn't FEMA. It was an outside group that,
the consulting group.
yeah.
Yeah.
Contractors or
Yeah,
whatever.
that's what they were. They were a contract group.
All right. Well, I appreciate it. Thank
Yeah,
you.
we need to know that people are talking all over. We want to make sure they get the truth, you know what I mean? That's what it's all about.
Yeah, we don't want any rumors like that.
Yeah.
Okay, well, you can tell them no FEMA contract.
Okay, thank you.
Thank you. I
Okay,
appreciate it.
one short question, we're behind already.
Very short. My name is Wendy. Thank you again also for letting us into this meeting and being part of our central district to participate. I have a data question I want to clarify. I've emailed and called a number of times and have not been able to get the information from your office. We saw that Adams rescinded all of their COVID-related regulations recently. As of last week on your website, Adams County showed 2 quote-unquote COVID deaths. Gem County showed 5, this was last week, COVID deaths. In Adams County, with a population of 4,300, this was from July of last year, I couldn't find current census data, that would put it at 0.046%, even if those were causal deaths. And in Gem County, with a population of 18,000, those 5 deaths put it at a rate of 0.027%. This is using July of 2019 data, so we know with population growth that would be even smaller if we counted the last more than a year of growth. And I'm just wondering what those deaths mean, if you guys could be more clear on defining them. On the website, it's pretty vague. And if Adams County said that their 2 deaths were not directly causal, it seems Gem County is doing even better than Adams County, and maybe Gem County should follow, you know, the lead of Adams County. And I'd like to know what those 5 deaths mean in Gem County.
Well, it brings 5 people died. I'm from Gem County.
It doesn't say 5 diabetes deaths or 5 heart attack deaths. It
No,
says 5 COVID deaths.
If I understand correctly, and Dr. Summers can probably tell me exactly, but basically these deaths are what is put on the death certificate by the attending doctor, is that correct?
Correct.
Okay, so it's up to the attending doctor
So,
to state.
well, I know of one that was in a wreck, or not in a wreck, but by natural causes of cancer. I thought to the people of Jim County. And it also said cancer, and it had a slash COVID.
So, so what happens when you fill out a death certificate is, you know, you can argue, everybody dies when their heart stops and they quit breathing. And you can't put cardiopulmonary arrest as the cause of death. You have to put why the reason is, so heart attack, myocardial infarction, pneumonia, whatever. But then they ask for other conditions that are part of that. So if the patient's diabetic, hypertensive, high cholesterol, hyperlipidemic, smokes, those get entered. If the patient dies of a heart attack and has a positive COVID death, you should put that down because it is well described that COVID can cause heart attacks and can cause strokes, can cause clotting disorders. So that's where that's coming from. That comes from the physician who fills out the death certificate. Reality is, somebody has a heart attack and they're positive for COVID. Do we know for a fact that that was because of the COVID? The only way you're going to know is to do an autopsy. We don't do a whole lot of autopsies, frankly.
They're very, county pays for a lot of.
But the other part of it is, you know, so you can argue that patients, you know, some of these patients who are ranked as COVID deaths, maybe COVID wasn't part and parcel of the death. But I've also read articles that we are underestimating the number of COVID deaths because they didn't get tested for COVID. They had a heart attack, they didn't get tested. Guess what? It was COVID. And so, you know, I don't know. Unless we do autopsies, we're not going to know perfectly.
So perhaps it could be just more clear on the website, because the way it reads now, it is a COVID death, and we're saying we really don't know, and that there are confounding and comorbid factors, and Adams County said their two deaths were not causal, and it just seems like.
How do you know?
Want to be.
Were they positive for
Well,
COVID?
let me answer that for you.
I'm not saying I know that, I'm saying that's what Adams County said.
All right, we're going to take 2 minutes and then we're done with this. We've got to get on with our meeting.
Let me just answer, make one.
Okay, Vicki?
Okay.
You got a minute.
Yeah, it won't take long. The one death, the other one I won't comment on, there were comorbidities, but the one death I talked to the family, and they were really upset. The man was, he had been tested for COVID and was negative because he was having some heart issues, but he was negative, and, you know, when he passed, he had a major heart attack, and his family was pretty upset over the fact that he was positive for COVID. She said he wasn't even around anybody. There was no COVID anywhere around. So it is airborne, so there's that. But anyway, that's what happened. And so it was after he died, then they tested him in hospital, or while he was having the heart attack. I'm not sure which, but he had a heart attack before he got to the hospital. So anyway, that's that. And COVID was listed as the third cause of death on the death certificate. So the family just said that the doctor said, well, he tested positive for COVID, so that's why they put that down there as the third cause. So it doesn't probably say /COVID. It probably has a cause and a cause and a cause. So
Are the list of diagnoses on the death certificate listed in order of severity? Thank you.
No.
No? So the cause of death is not always listed first?
Didn't get an answer that you'd like, I know,
No, it
but,
is.
That was good.
you know, it is up to the attending physician.
Yeah, and I think the data needs to be clear. So on the website, instead of saying it is a COVID death, it should say, which includes confounding comorbid factors. This is people also because of the doesn't apply to the way it's stated right now.
Okay, well, that's something we can take into a thought process. I don't know how that has to be listed legally.
Yeah.
Into our system requirements, so we'll have to follow those.
Anyway, the numbers are super small.
Yeah, well, I hope they stay that way.
Yeah.
But you never know. Okay, thank you very much for your participation. We do appreciate your interest and your concern and your thoughts. Yeah, no, I've got a bunch of those myself. Anyway, we're back to staff. Introduction of new employees. Who's doing that?
Carol has one. I have one.
Okay, Carol.
Okay, I have Nancy Reyes, our newest RN with Nurse Family Partnership, and I'm going to let her take my seat and introduce herself.
Okay.
Hi everyone, I'm Nancy Reyes, and I just joined the NFP team. I'm super excited to join the team and be help out the community. Nice to meet everybody.
Nice to meet you.
Nice to meet you. Thank you for being a part of the team here.
We definitely need help.
Yes.
So thank you very much.
Yes.
I know that's a limiting factor if we don't have the right personnel.
Yeah. Well, thank you so much.
So welcome.
Thank you. Thank you.
Okay, thank you.
Bye.
Is that all, Carol?
Yep, that's all I have.
Okay, well, thank you very much. Next on the agenda is the approval of the last month's minutes.
Welcome.
Mr. Chair, those minutes looked accurate to me, and I'll
Okay.
make a motion, we approve them.
All right, I have a motion.
Okay.
And a second. All in favor of approval, say aye.
Aye.
Aye. Thank you. Motion carries. Looks like Troy is up for expenditure and revenue report.
We're gonna be in Hawaii or?
Good morning, everyone.
Where are you at this morning, Troy?
Well, I wish I was actually here. Wherever this is, I think it's Hawaii, but I'm not 100% sure.
Still, my
I know,
goodness.
right?
You taking up residency there, or what?
Yeah. Let me rotate one more. Okay, so if you'll start starting with our packet this morning, you can see that we are, for the month of September, we should be 25% along in our expenditures and our revenues. And you can see, let me pull this to like this bigger so I can see it. Well, I'll just squint.
Kind of lost the last little statement there.
Oh, sorry, I was kind of mumbling a little bit. Sorry about that. So when you're looking at at our cash position up in the upper right-hand corner, you can see that our total cash position is still kind of in the positive, meaning that we've had more revenues coming in than we've had expenditures. But for this month, that's not quite the case. For September's representation, we're actually the other direction. So if you remember the first 2 months of the fiscal year, we had monies that came in from fiscal year 20 for work that we had done on COVID that had not been billed until fiscal year 21. And so those revenues come in fiscal year 21. So that's what's kind of creating this kind of false perception that we are in the positive. So the actual, if you kind of look at the way that our revenues and expenditures, particularly our revenues, have happened as we build each of the different funding sources, we kind of create this almost like roller coaster pattern where we have revenues coming in, and then we have expenditures, and then we have revenues coming in. So until I can get some of these grants stabilized, that'll probably be the case for the next couple months. For October, so far, we've probably had now more revenues than expenditures. So when we look at October's report in November, we might actually see that roller coaster back the other direction. Again, it's just based on when expenditures happen and when those revenues get reimbursed. We're currently working on a couple reimbursements through both the CFAC funding, which comes directly from the governor's office, And then we're working on some of our federal, some of the grants that we're working as subrecipients, some of the activities that have been passed on from the Department of Health and Welfare. So we have some billings that are currently in the mix for those. And so I'm anticipating that change column where you see over there to the right, where that's a negative number for this month, I'm anticipating that'll be a positive. But the reason, if you can look, and like we've talked about before, in that change column, you can see our net revenues for September were that 787,000, and then our expenditures were at a little over $1 million for September, leaving a net cash position in the other direction of $272,000. But our overall net cash position is still positive based on from July until now. So when you look at the different revenue types, you can see that as an example, and this is so small, I'm trying to, maybe if I move it over here, it'll just look like I'm looking away. You can see that our fees are just about right on target overall throughout the district. And you can kind of see each of the different areas inside of the district are kind of at a different rate. The clinic services at 32%, environmental health is at 49% total revenues of where we anticipate ourselves to be. General support is at 23%. So as a general rule of thumb, our revenues are a little bit ahead. And the reason for that is because of the billings that we've done for COVID. So that those revenues, and a good chunk of that is like I mentioned, is those revenues that we received early in fiscal year 21 for fiscal year 20 work. And so that's why those revenues are a little higher than you might anticipate them to be. If you look at our expenditures, however, we are moderately on track with the budget at 24.8%, or we should be at 25%. So that's not too far off. Our personnel is a little bit high, but our operating and capital outlay is still a little bit low. So as a general total, we're at about 24.8% of our expenditures. So that is kind of the broad picture of where we sit from a cash standpoint. If you flip to the next pages, you can see then the graphs, and for the revenues, you can see then and if you're looking at that very first column, that really high blue is, again, those are some of the revenues that we received from fiscal year 20. And then again in August and September, there wasn't any more of those fiscal year 20s trickling in and some of that backlog of billing. So that's why you can see that it's down. I anticipate October to be a little higher because some of those billings will come in and we'll kind of repeat that roller coaster a little bit. But you can see that our contracts, our district funds, and the contract billings are what's kind of roller coastering. Everything else is staying moderately stable. In our expenditures for the graphs, you can see that when we look at kind of the blue columns as personnel, again, they kind of tick up as we've hired more folks for COVID and dealing with COVID response. That ticks up a little bit. Our operating costs is higher for September, and I think that contributed a little bit to the upside down that you saw on the first page. And that was because the crisis center payment, actually we made 2 crisis center payments in September. And so in that, it really determines on whether or not how soon they bill us and how that gets out the door. So that wound up to be 2 payments in September. Then the final graph is our investment yield trends. And again, they've stayed pretty stable or static with where the interest rates are. So you can see that as the interest rate falls, you can see our return also falls. And that is across all 3 of our investment accounts. And then that is the end of the graphs. Did anyone have any questions or thoughts?
Questions, commissioners? Doctor?
Good clear report.
Yes, Kelly.
My question is how is the funding coming back on the CARES Act? Are we getting reimbursed quickly, or is it taking you some time?
So that's a great question, Commissioner. We actually have just started. We haven't actually billed any of the CFAC funding yet. We've been primarily leaning on some the sub-grants through the Department of Health and Welfare. We just had some conversations with Sarah Stover over at the governor's office. There was some kind of misunderstandings, I think, with regards to how that would impact our appropriations. So we got some really clear guidance, I think, this past week regarding how that any billings that we would have toward any of those CARES funds would impact our appropriations. So our current strategy at this point is to start billing those CFAC funds that are available to us, but only in an environment where it won't impact our state general fund appropriations. So at this point, we have some pre-authorizations into them, meaning we had some expenses that we would like their permission before we actually expend the cost. And then we have some expenses that I'll be turning to that source in probably the early part of November. So again, part of that roller coaster is we've expended expenses in the past that won't get reimbursed in probably till December. And so at this point, I honestly don't know the answer to that question because we haven't billed them yet.
Okay, thank you.
Thank you.
Is it just on the CARES Act money that has to be spent by December, or is that all the appropriations?
So it's primarily
available right now.
Yeah, it's primarily the CFAC funding that has to be spent by December 31st or 30th. So that's why we're trying to turn as much as we can there. The other monies I think are going to be available a little bit longer. Those are the ones, though, I'm a little nervous about hitting our general fund appropriation. So we'll probably have more conversations about what to do with that in the long term.
Okay. Do you have equipment or other things that you're buying that are possibly not available, so you can't bill by them? I know in the county we're kind of looking at some of that, and we don't know if we can get some of the equipment that we'd like, to try to cover some of the CARES, the COVID-related stuff we have to do. Anyway, that's a concern. I was wondering if that was any of your concern also, or not.
Yeah, Commissioner, I think that's a great concern, and one I think I'm not 100% sure I know the answer to. I can do some more digging. From what I understand, the only pre-authorizations I have in the queue are 2 items that we had requested for their authorizations on. I'm not aware of anything additional at this point, but I can certainly ask that question.
Okay, just wondering. Okay, well, thank you. Is there anything else, sir?
Mr. Chair,
yes.
I don't know, Troy, if you've heard anything about this, but I know that there is a bill at the federal level that's being bandied about back and forth across the net between the Republicans and the Democrats as far as extending aid from the federal government for COVID-related things. And from what I understand, part of that bill would include extending past the December 30th time, the availability of funds. Are you aware of any of that?
Yeah, Commissioner, I have heard that. I don't know the actual outcome yet. I had heard that language was being proposed, and at this point, I don't know that there's been any decisions made, but
there hasn't been.
I think, from my standpoint, I think that's probably really an appropriate step. I can't imagine that we would have that. I think and this is just my own opinion, that from a nation standpoint, that we would be at the point where that funding should stop, because we obviously have the ongoing effort. So.
Right.
Mr. Chairman?
Yes.
Commissioner Dale, just in follow-up to your question as well, we happened to talk about this last night on our call with the governor's office and Health and Welfare and the other directors, and the Department of Health and Welfare indicated they did not have any new information to provide on the topic, basically, that you brought up.
It has not. It's still being negotiated, shall we say? Yeah.
Okay, any other questions or comments for Troy? Do you have anything else for us, Troy?
No, sir, I think I'm good.
Okay, well, we think you are too. So
Yeah.
thank you very much for this
Thank
report.
you. And I'm just hanging out on the beach, so.
Yeah, I can see that, I can see that.
With the
How
clock above my
come
head.
your cans aren't getting any better?
Get a hat on that bald head.
Right,
Yeah,
I know
no
it's so
kidding.
shiny.
Yeah.
Thank you, sir.
Okay. All right, well, thank you. We're behind schedule. We'll jump on to groundwater monitoring.
My name is Brigitte Grunberg, and I have been working for Southwest District Health for a little over 6 months now. In environmental health, I'm an environmental health specialist too. I've been working for the state off and on for about 10 years for 2 other health districts as well as the Department of Ag. And I'm here to talk to you guys about groundwater and some of the things that I've been seeing and some of the struggles with it. And so some of this might be review, and if it is, I apologize. I'll do it. And please stop and ask questions if you have them.
So Ashley is going to drive your
Oh, okay,
PowerPoint.
perfect.
And so if you could just audibilize when you're ready to have her advance, we'll take care of
Okay.
that for you.
All right, go ahead. Maybe.
She can hear you, but I think she's waiting for a response.
There we go.
Thank you, Ashley.
So this is just an overview of the rules and regulations. So I'm sure you guys know this. So the rules come from IDAPA, the Individual Subsurface Sewage Disposal Rules. That's what we follow as an EHS out in the field. And I feel this is really important. These rules are in place to protect public waters and to protect the public and general welfare of Idaho's residents and visitors. And then there's the technical guidance manual, which is mandated by that rule, and it's established to put criteria in place for alternatives to standard systems, and it's also a great guide for us EHSs and installers in the field. It kind of just elaborates on the rules. And then we have internal SOPs, which are internal policies for items that are not addressed in the TGM or just need a little more clarification. Okay, go ahead. This is kind of, do I need to overview? Does everybody know how a septic system works, or would you like me to go through this?
Yeah, you flush it and it goes away.
Yeah. This is not.
What do I need to know?
I'll just go through it, like.
It comes back up.
Yeah.
Then you have a problem, right?
That's a single system, that's not a municipal system.
This is just a basic individual septic for a homeowner. Yeah, this is typically what you'll see at maybe your house, residence that doesn't have city sewer. So you flush it, it goes into the septic tank. The septic tank is the first, primary treatment. So basically it separates. You got your floaters or like your greases and stuff that floats to the top, and then the sinkers, you could call them, go to the bottom, and then the goal is to have that clear. This isn't a pretty topic, right? And then you have the goal is to only have the clear or, liquid portion go into the drain field, which is where your secondary treatment happens. And you have several layers. We want at least 4 feet of good soil underneath that for that water to filtrate through the soils and the bacteria that's in there to start eating up that stuff. So that's kind of general overview of a septic system. It's important to have your septic systems pumped every 3 to 5 years, which is try to tell homeowners, especially if you have kids, do it definitely more often. Okay, next page. This is just an overview of the required separation distances for the TGM and the rules. We have 3 different things here. So we have fractured bedrock or other porous layers. We have a lot of, lava rock that we'll see. So that's an example of that. And then you have your normal groundwater. And this is also dependent on what soil type you have. So if you have a really permeable soil, such as sand, you need a bigger separation distance as opposed to clay which is a lot smaller, and there's a lot more cleaning and filtration that happens in that sand, or in that soil, I should say. And then you have your seasonal high groundwater, which is across the board. You have to have a system that has to be installed at least a foot above that. There's also secondary treatment, which can reduce all of these separation distances, which is really important when it comes to groundwater, or fractured bedrock for that matter. Next. So groundwater, what is it? It's any water of the state which occurs beneath the surface of the earth in a saturated geological formation of rock or soil. Any questions? Next. So why is it a concern? Groundwater contamination, if a drain field is placed in or near a seasonal high or normal groundwater, the drain field will, not may, it will contaminate the groundwater. And then saturation of the drain field. So if a drain field is already saturated with groundwater, it's not going to clean or take any more liquid. So what happens is your liquid goes up, and you end up having sewage on the ground, or you're contaminating groundwater, and it causes your septic system to fail. Is this going to happen right away? No, but it's going to happen a lot sooner than expected. So therefore, before a drain field is placed into the groundwater area, the seasonal high and normal groundwater levels must be established. Next, let you some math. Presenting with math. So you need to establish your seasonal high and normal groundwater levels. How do you do this? This is straight from the TGM. High groundwater level may be established by the presence of what we call low chroma modeling, which I have some pictures of that. So it kind of looks like a rust layer in the sand. It also presents itself as like a gray layer. In the chroma modeling, it can be like almost like dime-sized pieces, or it can be just like a straight layer all the way across. What that is when that water is constantly rising and sitting in that area, that soil is pulling out or stripping the groundwater of its minerals, and so it leaves this clear line showing where that water is. And then you can have a historical record, so what kind of groundwater monitoring has done before in that area, or there's a program called Web Soil Survey that we use too that can help. And then groundwater monitoring, which is honestly the best way to determine where your groundwater marks are. Next. So we want to establish two different things. Your seasonal high, it's the highest elevation of groundwater that is maintained or exceeded for a continuous period of 1 week. And then you have your normal groundwater, which is the highest elevation of groundwater that is maintained or exceeded for a continuous period of 6 weeks. So when people say, I have to groundwater monitor for a year, I said, no, what we're trying to do is establish that 6-week period and that 1 week period. If we can get that, then we can stop groundwater monitoring. Next. Okay, so here's an example, and it might be hard to tell with the light. This is the low chroma modeling that I was talking about. Can I go up there? Go for it. So it's hard to tell, but in this picture, it's right here. Yeah. And then this part right here, it's hard to tell, it's a lot darker and it's fully saturated. So even though the water shows lower, this fully saturated water is actually where the groundwater is sitting in that hole. It usually takes about 24 hours for when you dig a test hole for that water to kind of settle back to that spot.
So that's when we see this question here. So when we have a subdivision or a house permit come through at the county level, and they say they've done their test holes, this is what they're doing?
Yes, they're digging a hole, and if they have groundwater, then may require monitoring. Okay. But yes, this is part of what we're doing, and we're also evaluating the whole site in general, not just the soil type. Okay.
May I ask a question?
Sure.
Go back to the monitoring, a subject near and dear to my heart. How do you know where the high seasonal is for 1 week if you only look at it for a short period of time? It may occur at a very different time of the year than what you're looking at.
So couple parts to that question. It depends on what we're looking at. So there's the irrigation season, which is actually what I'm going to talk about next, which is typically late summer to October. So irrigation season will cause that groundwater to come up very high. And that's actually very typical in Gem County, and also in Stark. And then you also have your spring melt,
Right.
which is from rivers, or you'll see a lot of times in the mountains, which also can cause a peak. So the only really way to do that is to monitor weekly and hope you don't miss it. You know, we've had really good luck.
But it does take longer than a week, right? You're looking at a long period.
Oh, yes, yes. I'm saying that you can sometimes establish it if you do it at the right time of year. You can sometimes establish it a lot quicker than you would if you started now, because we're not going to have a peak. We're going to have to wait till the end of the summer.
So for somebody that wants to get a, you know, a buildable lot or whatever, they're going to wait for a year till that gets monitored, or what does that do for the homeowner or for the builder?
So technically, in order to do it right and to get the best accurate measurements you can, that is what should be done. Yes. I know that's not realistic, and it's because of when the homeowner wants to build. So what I've been trying to do now, I would like to do more groundwater monitoring because, and I'll give you examples in a minute. I've been using that high mark, the modeling mark, as my seasonal high, and then I just take layers all the way down and feel how moist the soil is, what it looks like, and that's what I'm using to determine my normal groundwater. Is it super accurate? It is that's what I have, without doing an additional groundwater monitoring to show those levels. So what that may require is them to put in a secondary treatment system. If we, as opposed to just monitoring, maybe they wouldn't have to. I don't know.
At what point would they know this?
Well, I would tell them right on site. We would tell them on site, you know, it looks like your modeling is at 15 inches. So if I'm going to base my permit off of this and not doing groundwater monitoring, we would be putting your system in at, you know, you'd have to be a secondary system, like a Presby, to meet the setbacks of the rule. So they would know right away.
Okay. I'll take that.
You know what?
I'll take that.
With new subdivisions, where we have several lots in a high groundwater area, I think it's very important to do the full year of groundwater monitoring, put wells on every lot from the get-go. Next. Okay, so this is an example of a groundwater monitoring well. It's usually installed at the same time we do the test hole, and I always tell the installer ahead of time, I think this is a groundwater area, let's bring a pipe and some geotextile fabric. It's a perforated pipe, and you want to put it into the groundwater, and you want to line that with a geotextile fabric. That way that the soil doesn't start seeping into the pipe. We want to get accurate levels. And then you measure your pipe height, the pipe to the ground, and then your initial groundwater monitoring. And then this should be done every week on the same day to get the most accurate measurements. Any questions? And we want to cap the pipe as well. Next. So this is an example. This one is a little low to the ground. I was trying to find some good pictures. We want it actually higher than that, just in case there's irrigation or any flooding. We don't want our numbers to be skewed. So you see the geotextile wrapped around it, and the pipe is in the ground. And this is one, they put a cap on it, and they made it bright orange so you could see it. This one is interesting because you see on the left picture there's water in that pipe. This is why I think groundwater monitoring is so important. That's 11 inches from the surface. When I did my test hole, that's not what I saw. it was lower than that. So if you were to do a test hole and base it off of what you saw in the test hole, it could be different than what the actual groundwater is, and that's why it's so important. Next. So who is responsible for monitoring the water? The homeowner is. Okay, so it must be monitored once a week through the season, and there's 2 seasons. The one that we're particularly concerned about in this area is the irrigation season, which is April 15th through October 15th. It must be recorded, and then the EHS will come out and spot check it as often as possible and compare it to what the homeowner has reported. But it is the homeowner's responsibility or the builder's responsibility to monitor that water. We just simply don't have time to do that. Next. And then another overview of when, so irrigation season, and then some areas where this is a concern would be Emmett, Middleton, Star, and then spring melt, which is February 15th through May 31st, and that's areas like McCall or mountain areas. Next, or areas by the river too, but also other areas in Emmett. And this is just an example, and I won't break this all the way down, but this is kind of an example of what a weekly Excel spreadsheet would look like for measuring your normal and your seasonal groundwater. And then you take your high and then your normal or your average. Try to determine that. Next. Okay, so here are some examples of why it is so important to monitor. The picture on the left was about 2 months ago. It's a system that I went out to that was actually installed. I was going to inspect it, and it's sitting in groundwater. As you can see, the water decided saturated. It's because the system, when a test hole was looked at, it was done in the early spring when the water was at its lowest. And so it's hard to know where that high groundwater is without doing monitoring. And then the picture on the right is another system that they called me because they had questions, and I knew where this area was, and I said, wait, I want to come out there and I want to see your the test hole before we put the system in. And we came out here, and the water was in 12 inches of the surface of the ground. So, and it's hard at that point to say, I know your permit was written for this, but you actually need to put in this because this is the only thing that's going to protect the groundwater, especially when the system that you're requiring them to put in after the fact is more expensive because it's a secondary treatment system.
So could you just, what does a secondary treatment system look like when you've got high groundwater? What does that look like?
So a secondary treatment system allows you to put the system in a foot above groundwater. So you can just put it in way closer than groundwater. A normal system, just take B soil, for example, would be 4 feet. You have to have that separation between the soil. So if you have 15 inches of soil before you hit groundwater, you could put in a Presby, which you have to have 3 inches of soil, and you could put it in a lot closer to that groundwater than a traditional system. Or an Oscar, which allows you to even put it closer, is another example of a second. So it further treats the effluent before it hits the groundwater.
What is the cost of those treatments?
I don't know, actually. I don't know the exact, and I think every installer has a different, is a little bit different.
On the average, about 15,000.
Yeah, I could give you an average, but I don't know. And a regular traditional is anywhere, from what I've been told, 8 to 10. Next. So here's another example of a system I was looking at. So the picture on the left is a trench that was dug from the well to the house. They were connecting the water to the house. So that trench is not even, it's only maybe 2 feet, if that deep, and it was just filled with water. So it was my first clue. And then when I went out to go inspect the system, which is the picture on the right, that black pipe, that's actually that's a Presby pipe. So that is a secondary treatment system. and it's placed on sand, a foot of sand, and that sand you can see is wet.
Which means?
Which means it's in groundwater. Or very close to ground, a lot closer than it should be to groundwater. And that's actually, that one right there, the picture I showed you earlier of the modeling, that is actually what we found when we dug the test hole. So it was in 12 inches of the surface. Next. There's one more picture or not.
All right, so that appears to be the end of the slideshow.
Okay. And then one more example I'll give you. Yesterday I got a frantic phone call from an installer because he was putting in a system and the groundwater was over a foot higher than what the permit showed. And he was worried that he wasn't going to be able to make grade and he needed to put in a different tank than what he had already ordered on site. Those are some of the issues that come up. And so what do I tell them? Yeah, you can't put this in. We have to do something different because if you don't, you're going to contaminate groundwater. It's really hard judgment calls when you do a test hole and the only thing you're looking at is the layers, and that's why groundwater monitoring really helps. It's the combination of groundwater monitoring as well as the modeling and the test holes.
Well, Mr. Chair, I'd just like to make a couple comments here. I really appreciate this look at it. At first, I want to give a compliment to Nikki and is it Brigida?
Yes, thank you.
It's from like Sound of Music.
Yes,
Yeah.
it is.
I had a builder call me a while back and related to Nikki, and boy, you guys took care of that just like immediately, and he was very happy with what you guys did for him. So appreciate that. And I just want to say, I don't know if you guys are getting as much pressure as we are in Canyon County, but we're getting pressure to build out in the areas in the county, and there are always standard objections that come up, and this goes clear back to when I was the mayor of Nampa and on city council there. Anytime there's a new development or a new project that comes up, you can guarantee that somebody's going to say the schools can't handle it, somebody's going to say the roads can't handle it, and outside of the city, you're going to always have somebody say, you're going to contaminate my well, and I won't be able to have my water. And so it is critical, and our answer to that as county commissioners in Canyon County is that, you know, Southwest District Health is the governing body that tells you what you got to do to make sure the groundwater is protected so that you're not going to contaminate wells. And it's critical for us to know that you're doing your job and that you're making sure that these septic systems are where they need to be and doing what they need to be doing. So I really appreciate this look at it, because we're telling those folks that's Southwest District Health is taking care of that. And I really appreciate this walk through the whole process that you did. Really appreciate that.
Okay. Thank you for having me.
Yeah.
Anything else? Comments, questions for Brigida?
I have a question.
Go ahead.
And I guess it might be even maybe more for the board, but I was talking to Jamie about this and some of the challenges with timing, and as Brigida mentioned, the desired time to do groundwater monitoring before you start developing. I was wondering if, and this is maybe more of like a land zoning question or something, or land use, but is there any way to like almost kind of work upstream, like once a property is determined to like be residential, I guess, and developed, that maybe groundwater monitoring starts at that point prior to even like a purchase? Because who wants to buy I mean, I'm just thinking of myself, I live out in the country, I'm like, who wants to buy a property where you might find out that you have contaminated groundwater or you can't put in a good septic system?
There's definitely questions that way. We definitely have concerns that direction, but at the same time, we're also looking in Gem County at not only septic or groundwater monitoring, but also actual well monitoring. And the cost of that is quite substantial. And so just to turn a property into a buildable, you know, it can have a building permit, somebody's got to come up with 20 grand or so in order just to do that. And that pretty much, I think, I don't know that right now, but I think that would stand, not stand up in court that be required. That would be my concern. And, you know, and it would pretty much stop most development. You know, I mean, if somebody has a 5-acre piece and they want to turn it into, you know, if it's in the area that it can be rezoned, you know, say to 5 or 4 1-acre parcels plus your access roads and whatever, that would be 4 separate wells, 4 separate monitoring for the groundwater. Yeah, the cost would be prohibitive for anybody to do that, except for large developers. And I just I can't think that would be good for the folks.
You know, I just say, and that's really good, some good stuff. A question: how long? And I guess it would depend on what time of year you're doing the monitoring of a groundwater monitoring. But how long does that need to be monitored before you can safely say this is where you need to put your septic system?
So basically, are you going to put a 1-year minimum moratorium on a piece of ground before you can build on it? You know, I mean, there's all those questions that have to be answered, and probably ordinances changed if that ends up being the case.
It depends, and it depends on the time of year. So in June, July, August, it's a lot easier for me to say, yeah, you need to put a well in, and you have 3 months. You know, 3 or 4 months you need to monitor to get your average and your high. But now, say, yeah, you got to put a well in, and you won't know anything till October. That's a harder one to swallow for a homeowner. And
and guess I look at it kind of on the different side of it, and I understand what you're saying, but the other side of it is that these people who are wanting to build on 1.5, 2-acre lots out there, they need to know that they can safely have well water and septic systems.
I agree.
So we're guaranteed, we're by giving them you got to monitor this for 9 months through this period of time. Then they know without a doubt that their investment is going to pay off, and so it's kind of protection for that investment of that person. And what we're seeing quite a bit of is somebody who's lived on their land, and they've got 40 acres out there, and they want their kids to move out and have lots next to them and all this kind of stuff. And boy, they got to know that they can do that without. And for me as a county commissioner, saying yay or nay on this development, I need to know that if I say yes, it's not going to contaminate Vicky's well because she's been there for 65 years. Well, probably not that long. But you've been there a long time. I just use it. But we have these people that come in and say, listen, I've lived on this land for 30 acres, and if you allow those folks to build over there, my well's going to go dry, or it's going to be contaminated.
Well, and a lot of the older wells were quite shallow.
Yeah, that's
unless they had to be deep. I mean, there's a whole bunch of things that go into that.
Yeah.
And along your same line, one question that we've been really, really trying to get an answer to, and nobody will tackle it, is what is the saturation point? You know, if you have, you know, in a county, and there's small split subdivisions, whatever you want to call them, you know, so that in one area you've got 1,000 1-acre lots with a well and a septic on it. What's the saturation point? At what point can that ground not handle that and be safe?
Yeah.
See, and that's a really hard one to come up with. Basically, well, earlier on we had some of those folks from Southwest Health District. It's not here now, and they said, you know, we said, is it, you know, is there any generalized even. And then it depends on the soil and the, you know, the structure and the caliche layers and, you know, everything that's there, understand that. But, at some point, there's probably a saturation point. And, you know, and then everybody's messed up. And we have I have a lot of concerns for that. And, so we're instead of being able to go to 1 acre, which we're zoned for now, is our smallest zone in our county without, you know, a subdivision type ordinance and all that. But, that what we're thinking about going back to at least 2 acres, just because we don't know and nobody can give us an answer. So,
Do you have an answer for it?
No, I was gonna say, a lot of times in those highly concentrated subdivisions, these large subdivisions, where they're an acre, well, you know, it's been a nice.
But they're not all one large subdivision, they're just one here.
Yeah,
And then they keep adding, you know,
yeah.
1 or 2 at a time, and you can't force 1 or 2 at a time to put everybody, you know, into a community water
Right.
system, right, either well or septic.
Right.
It's anyway, that's not your problem.
No,
That's a zoning
it's
problem.
a struggle.
But it's
It's a
also,
zoning problem, but
it's potentially a health issue, though.
it is a health
It
issue
is.
that we're concerned about, so that everybody might be in problems and not just 1 or 2 persons.
Right. I have a house actually, you could look at it, it has this problem right now where it's been there for a long time. I went to go do a replacement and it's going just into the ground. But there's so many wells and they're all, because I called Department of Water Resources, all the wells are shallow. But all the wells encompass the setback is this person's whole property.
Mm-hmm.
So what do I tell them? You know, I can't tell them you can't not put a septic in because they have to live there. So it is a very real struggle, and I do see it. But can I make one more comment? Back to the year of groundwater monitoring, I understand that for homeowners, it puts them in a hard spot, but at the same time, it puts us in a hard spot because we go back to put their septic system in, and then I see a septic sitting in groundwater that they were given a permit for. That's really hard for us too, because
Then it's not safe.
it's not safe and doesn't meet the rules or the setback, you know, the rules or the regulations. And I personally can't say, I'm not gonna say this is okay when I know it's not okay. But you told me I could do this a year ago. You're right, I did.
Well, I really appreciate that, and I would say probably as we move forward, particularly in counties that are seeing more of this pressure out there, we're probably gonna have to, as county commissioners, step up our ordinances and requirements out there to do this more extensive testing, because we're thinking, we're not just thinking about next year, we're thinking that house is gonna be there for 50 years, and if you gotta wait a year because you gotta monitor the groundwater to make sure it's safe to put septic in there, I think that's worth it for us as people who have to look out into the future 50 years and figure out what's gonna happen here. The other message, and I don't know how we get this message, but your point to the shallow wells, and you said just also, Brian, is that, you know, I can give you a quote from somebody, so my well's we've been here for 50 years, and our well is 60 feet deep, and it's been fine. Well, you know, probably that well needs to be revisited after that length of time, because sediment goes in there, it stops functioning as well as it should. You're getting more sand? Yeah, we are getting more sand. Well, you probably ought to re-drill that and put it down deeper. And that's an expense that people don't want to do. And the other thing I'd just say, and then I'll be quiet and get off the soapbox, is that's one of the reasons why I think as commissioners, we try to encourage, we don't demand it or force it, but we encourage urban type development to be annexed into a city so they can access the sewer and the water system of that city and not have these problems. And quite often, it's cheaper to do that than it is to build out in the county and spend $15,000 on a septic system and another. How much does the well cost to drill?
10, probably.
probably 15,000-20,000 for a well.
Oh, yeah.
Yeah, easily, yeah. Anyway, that's the thoughts for today.
Okay. Tide?
Huh?
What brand?
What?
Tide?
Tide?
Gear?
Yeah.
Sorry, I
Yeah.
couldn't resist.
Yeah, yeah.
That was bad, I'm sorry.
It took me
I
all the
apologize.
time, I got it.
I apologize. Okay, well, thank you, Brigida.
Thank you, guys, have a good day.
We appreciate it.
Yeah, we don't have to worry about tide in here, we're not coastal area.
All right. Well, we're way behind schedule now.
Yeah.
But we needed that. I was glad to have that. I think it explains some things for sure, that's going on in our county, and have better answers here. Okay, COVID-19 situation update from Doug and Jamie.
Morning. Can you all hear me?
Yes, sir.
Okay.
We can see you.
Hopefully on your screen, but we'll see.
Yes, you are.
Okay. So the COVID update for the month, we are continuing to work towards operationalizing our COVID program into a day-to-day managed program rather than an incident response. To that ends, I guess we have been busy hiring additional staff. Recently, we hired our full-time public information officer, Ashley Anderson. You've met her and had the opportunity to speak with her even today, so we're happy to have her on board. We have several other positions out for hiring now to respond to our COVID incident, and hopefully once we start getting those positions in place, we will meet our deadline of December 1st for operationalizing COVID. I'm not going to say that we'll meet that date, but we're sure trying. So just a few updates for the COVID response. Since October 13th, we've actually completed 39 Binex Now tests here at the Health District. That was as of, I believe, yesterday, but I think we did a few more yesterday. We've had several positive tests that were done during that time. Our investigation team has completed about almost 2,500 investigations with 450 or so that they've attempted but not been able to complete for a variety of reasons. We've also had 302 teachers and students in quarantine and 81 of them in isolation over the course of the school year now. As far as the schools go, we've had, just in the last 7 days, we've had 45 students attending class in person that have tested positive, and 335 students attending classes in person over the 20 and 21 school year that have tested positive. We've also had 7 teachers in the last 7 days test positive, and 99 teachers over the course of the school year test positive. Many of the cases that we've found that were exposed at school later infected household members. Obviously, that is to be expected since they're in close proximity of other people. We've had probably the top 3, I think, exposures for school students have been either by friends, during after school hours, during school, attending classes, obviously, and then school activities, including sports or dances. On the public information side, we've been working on our new external website, healthiersouthwestidaho.gov, and hopefully all of you have been out visiting that website. That's our new COVID-specific website that we've put up for concerted efforts between community organizations and our health district specific response efforts. We also put out a lot of new public service address announcements, and those are both in Spanish and English. And we continue to push those messages out on a weekly basis. We've also worked with Canyon County, City of Nampa, the Hispanic Outreach Task Force, community leaders and partners to identify some additional public service announcements for COVID-specific related activities. I know our public information team has been putting out holiday guidance documents. And that includes Halloween and Thanksgiving. The winter holidays are coming up, so we're putting those together as well. And we're going to be putting all of those guidance documents on our website, as well as pushing them out over our social media platforms. We've seen a little bit of a decrease recently in the social media realm. It's nothing that is not to be expected, up and down probably on the time of the year and the messages that we're providing, but we're still getting messages put out on those platforms. Our public information team is continuing to identify gaps in existing messages that we have and collaborating with our community partners to try and reach the most number of individuals in our communities and provide them with the appropriate messages or appropriate information that can help them be safe. And as far as our logistics outreach efforts, we've provided quite a few items of PPE to our 6 counties over the last month, to include 96 items to Washington County Emergency Management, 100 items to Weiser Memorial Hospital, 203 to a Gem County private school, 750 to Canyon County agencies, 650 Gem County agencies, 27 Payette County agencies, and 190, I'm sorry, these are COVID testing kits that I'm talking about this last section, but 109 to Washington County for testing purposes. So quite a bit of effort being put into COVID response still. We're still actively working with our county partners and our communities to try and keep them safe and to provide them the best services that we can specific to COVID. And with that, I'll stand for any questions that you may have.
County Commissioners, any questions, Doctor?
Well, I guess I have a question, and I don't remember reading it, but the information was there. How are the local Southwest District Health hospitals doing bed-wise?
Doug, I can take that question.
Okay, thank you. I couldn't quite hear it as well, so.
So what's the Southwest District Health District's beds in the hospital? How are we doing bed-wise? Because Kootenai up at Coeur d'Alene is at 99%. Eastern Idaho, they are full or nearly full. University of Utah, the Utah hospitals are not accepting anybody coming from Idaho because they're full. Twin Falls is having to send people to Boise. I'm just curious about our area.
Yeah. And I don't know, Doug, do you have that information? Because I think I might have more current information.
No, I don't have the specific information. I know it's quite high, but I can't give you the numbers without doing some research.
Yeah, I don't have like the at moment picture, but I have been on some calls this week with some of our hospital partners. Definitely concerned, as you've already mentioned, the influx of patients from the Magic Valley into the Treasure Valley because of the capacity issues. So I know that right now the Treasure Valley, for the most part, is handling its COVID patients okay. I think the concern is if we start to have I shouldn't say start to, because we're already trending up in the Treasure Valley too with cases, not to the extent as other parts of the state. But if we continue on that trajectory, while there's also these pretty significant outbreaks in other areas of the state that are causing patients to be diverted to the Treasure Valley, we're probably going to have a problem. But right now they're managing okay, from what I've heard. At least the Nampa, St. Luke, St. Alphonsus, and West Valley and Caldwell.
So, yes, the question I have, we are seeing those numbers trend upward, and that should be a concern for all of us, because that's not the direction we want to be going. Do we have an idea of where these contacts are happening, where they're getting, and can we have an update on that, or is that available? Is it accurate?
Yeah, I think that question would be well addressed when Rachel presents here later. She has done some really good analysis for us lately, and can probably address that question better. So if we could table that question till later, I think that would be helpful.
And Nikki, Rachel has provided a comment in the comment box as well, and she has some other data available for the hospitalization numbers as well.
Great. Okay, so we can maybe have her give that update when well, it's up to, I guess, you guys, board, if they want to hear that now, or we could wait till she presents it later.
I don't see where it is on the.
It's down here where we have.
Update,
Health alert levels, but so she could present that information now if you want to hear it, or hold it till when she's on the agenda, whatever your preference is.
Nikki? Yes.
Go ahead.
Have you guys read this is sent to me by Megan Blanksma on the CDC. So is there a different language, I'm trying to read through this, relating to what we're doing, relating to Central District Health on our seniors in nursing homes and long-care health care facilities? Because I'm trying to find something in here that allows, family members to take their loved one out of the home for, a day to do something with them, even if they took them home. And right now, they're not allowing them to do that at all. So basically, you could go see them there, and that's it. And that's a pretty restricted business as well. And because I guess the homes, the facilities are being threatened with, we'll take your license away if you don't do it the way we want you to do it.
Mr. Chair.
Yeah.
So I would like to clarify that the public health districts do not have the authority to take away any business licenses. So that's not.
No, this is but Health and Welfare does. Is that right?
They are the licensing entity, I believe. Okay. Yes. So.
I knew that. But okay. That's what I'm asking. Do we have anything different? But
no. So we don't do that, and so Central District Board. Not this most recent meeting, I think maybe the meeting prior, but maybe it was the last meeting. The board did ask the staff at the district to develop guidance, I think, for long-term care facilities to help the visitation process. So to basically put out guidance that would allow for safe visitation. And I don't know that is explicitly to my knowledge, we're not prohibiting visitation. Each facility, I think, has the ability to make that decision on their own. Doug may have an update on this because I actually had asked them to maybe reach out to Central and see what they were doing and if it's something that we should consider providing guidance on as well, because some of the long-term care facilities have the same ownership between our two districts. So I don't know if Doug has update on that. Maybe I'll pause here and see.
No, we're actually still waiting on working with Central on any shared guidance. I haven't been told of any updates on that yet.
Okay. Yeah, Mr. Chair, just a quick comment on that. It's similar to the comments we get. There's some. I've read one in here. If there's no mask mandate, how can a business mandate masks on their business? It's private property, and a private property owner has the right to set the conditions upon which entry into their property is allowed. And it's not government doing that. That's that private owner of that private property setting the standards. Most of these, I think most of these, maybe all of these long-term care facilities are private enterprises. They are for-profit businesses, and they are concerned about protecting their residents, their people who are there. So they are the ones who have the right to set the conditions upon which people enter or leave their facility. And I think that's what's happening. The health districts can give guidance, but as Nikki said, we're not in the business of taking licenses away or threatening anybody. And we have to respect the private rights of private businesses. And that's part of my philosophy as an elected official, is private property rights. Man, that's right up there with the highest of values that we as Americans say we hold. And if you don't want to go, if you don't want to abide by the conditions that Albertsons or Fred Meyer's or whoever puts on entry into their facility, that's still their right to say that. So anyway, I just,
Mr. Chairman,
that's just sort of another.
No, I'm not, that's not where I'm going at all. So if that's the case, absolutely. But if the facilities are saying to the patrons that you can't do this because our license is being threatened, it's not being threatened by us. There's no question about that. But they're saying it's being threatened by health and welfare. So somewhere along the line, yes, it's private property, and they can definitely decide that. So you could take your loved one to a different facility that you could work with better. But I mean, I'd like to know: are they being given guidance from us? Are they being given guidance from health and welfare? And is this?
Sure.
Is this what's actually happening? Because if they're worried that they're going to lose their license, because all school districts aren't the same, everybody's not putting out the same message. You know what I mean? Yeah. So I just want to make sure that people aren't left alone. When they could be, spending time with their families.
Yeah, I totally get it. I had my husband's grandmother, 102, just passed away, was at Karcher Estates in Caldwell, and it was hard because they did close. It was their decision, but they closed their facility to visitors, so that was pretty tough this year. But to answer your question, yes, we work with those facilities, particularly when they have COVID occurring in their facility. I mean, that's something we would normally do if they have influenza or other outbreaks going on. And again, more as a role of guidance and recommendations. Department of Health and Welfare is the licensing board, and my understanding, and I think this is maybe published on the state's website, but they had been doing some inspections over the summer and found that some facilities had what they would consider findings for poor infection control practices. And so I know that they have been much more engaged with facilities trying to have those facilities meet the standards for safety and health. And then, so I don't know to what degree there maybe is some threatening of licenses there. I can't really speak to that, but I can kind of put two and two together, I guess. And then the other piece that I don't fully understand is it's not my area of expertise, but I do understand that CMS, the Center for Medicaid and Medicare Services, also has a little bit of a hand in what these facilities are doing because they hold the purse string. So they may require certain measures to be put in place for reimbursement if there's COVID detected in the facility.
It's all about money. Yeah. In the end? No, in the end.
Did I answer your question, Commissioner Purdy?
Well, yeah, I mean, sort of. I just kind of want to
make
it clear. So is there a contact that somebody can go to find out exactly what's what? I mean, as if I've got my mother in a facility, which, my mother-in-law just passed away too at 97, and we were told they couldn't see her at the hospital, so they were going to take her back out and take her back to the living facility where it was easier to see her. So, I mean, nobody knows what's real and what's not real, or who's making the policy, or, that's where I was going with that.
Right.
So there's got to be somewhere people can go and somebody can talk to, and maybe health and welfare is where they really need to go, because we're not forcing anything on anybody, really.
Yeah, that's a good question, and I'm not sure. Based on what little information I do know about the facilities, I'd say either start with the facility or start probably with health and welfare if you have concerns about the safety or health standards in one of those facilities. But I also know that the residents are not prisoners in the facilities in that sense. They have their own independent rights from That's one thing that we've faced a little bit of a challenge, not necessarily a bad thing, but when some of the facilities were trying to determine how to isolate or quarantine patients who were positive for COVID from other residents, one of the opportunities, I guess you could say, that came up is other facilities were saying, well, we can be designated as a COVID facility. You could have those residents come over and stay here until they're better, and then they can go back. Well, those residents, that's like their home, their apartment for some of those that are really just there for the pretty independent. And the facilities were like, we can't force them to leave and go to another facility. So, which I was like, okay, that didn't really make sense to me, but now that you frame it that way, it really makes sense to me. So I totally understand.
Well, and then the confusion out there of who's causing what to happen.
Right.
We dealt with a facility in Caldwell that was saying, well, my mother's having to be locked into a room. She can't get out. Well, the facility cleared that up. That's not happening. And the other thing is some of the confusion out there when somebody goes up, I had somebody call me and say, well, I went up to WinCo there, and WinCo said, Southwest District Health said that we had to force everybody to wear a mask. I said, no, that's not, that employee is not accurate in that statement. And, you know, that communication out there is not accurate often.
And it's easier to make somebody else the scapegoat.
Right.
Yeah. Well, you know, we got to remember that yesterday, the governor also put us back down to 3, which did, just stage 3, which did put more restrictions on, and very clearly, on homes, senior homes. So,
and one of them was a mask mandate.
Yeah.
and that was done by, you know, that was the governor, and he, you know, right, wrong or indifferent, he made that decision. And it goes back to that.
Anyway, yeah. All right, was there anything else, Doug?
No,
Maybe
sir.
he left the meeting.
No, I'm still here. Sorry. No, sir.
Hey, we're taking a nap.
You know, sorry. Any other questions or comments for Doug? If not, we'll move on. Was Jamie also going to participate in the update?
No, Doug took care of the update for me. Thank you.
Okay, very good. Clinical operations update, Carol and Clay.
Okay, I can't seem to get here we go, my video back on. The first part of my update is I wanted to invite all of you over to the clinic area for the seasonal influenza vaccine. So we have nurses ready for you after the meeting if you would like to have that taken care of today. Then the next part of my update, our Marsing school nursing program. We have an RN at Marsing School Hub area 1 day a week. And this looks to be a great venture. And we may advance hopefully to more days as there are funding possibilities that might appear. One of the newest ones that I haven't got all the information on, but it's integrated behavioral health and primary care. So we're hopeful this will bring forward some more services. And then also a model of whole school, whole community, and whole child. And I believe that's through YCAP. And then the other update, this last Friday and Saturday was a partnership event at the Marsing Hub at school, both days. And we participated in that and brought forward the flu vaccine. And also we had cardiovascular screening for heart disease and stroke prevention. The partnership event included vision checks and glasses. This was through Love Heals. And this is a company out of Garden City area. And then also they had food boxes available. And Terry Riley was also there. And I participated Saturday as a volunteer, and it was well attended. They had it very safe for all of us to work there and clients to come in. They had appointments. They screened everybody. And we saw for flu shots, about 60 participants from that, from babies up to seniors. And the cardiovascular screening, I'm not sure how many the total number yet, but it was very well attended for that. And we had what I felt like was great participation, and you could see there was truly a need for that type of a clinic out there in Marsing, and the hub was perfect for it. Let's see, the other additional thing for the health department, we received another sub-grant funding for increasing influenza coverage among high-risk population. So we will be taking our team out to some community sites where we're trying to work through a possible drive-through type of a clinic at a fire station, and then some walk-in and Saturday clinics, and reaching out to our other counties to see where the need is at and how we can provide for the influenza vaccine. And then a quick update on staffing for clinic services. We are going to start recruitment for 2 nurse practitioners, each of them part-time, to work 1 day per week to help meet our current client needs in the clinic. And we still have Molly as our 1 day a week nurse practitioner. And she has a passion for assisting us with our new model in the community of schools for more access and mobile clinics. And then we're going to recruit for a PM2, program manager 2, to help manage the medical clinic and help grow our business towards our new vision of the school sites, mobile clinic, and then our take a look at our clinics in all our areas. And that's it for me. Dr. Roscoe?
Sure, thanks, Carol. Good morning to the board and everyone in attendance. I just want to start before I go into my couple of points, update points. I want to give a little bit of background information on our current NP, Molly Prangaman, who's been fantastic to have on board. And with hopes that this may answer maybe any questions that any of the board members have to the Carol's point that we're recruiting presently, trying to recruit 2 additional NPs. I hope that everyone's aware that Mandy Raynack, our full-time NP, has moved on to a new professional opportunity. And it's given us, the health department, an opportunity to take pause, look at what the community needs are, and make a meaningful pivot in the clinical services we provide. So Molly's helped us think outside of the box, in that she is a full-time professor at the nurse practitioner program at BSU. And the way that these training programs are structured, they leave a day a week on average for nurse practitioners, for example, in her program who are involved in academics to maintain a clinical practice. That's become more difficult for academic nurse practitioners and PA faculty, physician assistant faculty, to locate and maintain a single day a week clinical practice. But this was a very, very good opportunity for Molly with her specific interest in public health and community-based health. So it's been really nice to have her on board and help us think through a new model. So the recruitment for those 2 nurse practitioners, 1 day per week, why is that? We're attempting to target more advanced practice nurse practitioners, or potentially physician assistants who are in academics. One of the value adds of that is they come, they're 1 day a week, they're part-time, and issues like additional benefits, health insurance, retirement plan, whatnot, that's covered by their day job. And then they also, equally importantly, bring a wealth of clinical experience to the table. So we've just started the recruitment process, but very hopeful. Molly's assisting us. She's also very hopeful that we will find some additional faculty who may be interested in working at the health department 1 day a week. And then moving on to my points, with Mandy now gone, there still is ongoing reproductive health needs that are at the health department. We have a patient panel that routinely accesses us for their reproductive needs. And I and Carol and Nikki are in active discussions with FMRI NAMPA, the new family medicine training program, about potentially staffing a once-weekly reproductive health clinic. This would essentially be a faculty professor or a faculty physician and a physician in training who would rotate. It would be physicians in training that would rotate through on a regular basis, that would come over to the health department at the Caldwell office and provide reproductive health services, as well as with some support by myself. This probably would be 1/2 day per week is the model that we're currently looking at and discussing. They've signed their chief resident to be point of contact to further explore this, and FMRI NAMPA is very, very interested in this opportunity if we can make it work, because it's always a challenge for physicians in training to get exposure to reproductive health services as part of their training, especially procedures. So that's going to be things like IUD, placement for birth control, as well as colposcopy for cervical cancer screening and treatment for precancer. These are all things that can continue to happen at the health department, and they'd really like to be part of that, so we're continuing to explore. Doug mentioned, on to the next point, that we are now actively testing for COVID using the Abbott's rapid antigen test called Binax Now. This is a little different from the test that we were previously using as a rapid test, which was also an Abbott product called ID Now. Antigen tests look for a protein or a particle of the virus, protein particle of the virus, whereas PCR testing looks for genetic material that belongs to the virus. The ID Now we did use with success, but it's a little more challenging rapid testing platform to use because you can't move it around. It requires a small machine that every place that you use the machine, you have to do validation studies first and make sure it's okay before you actually go and start doing testing. Whereas the Binax Now, the antigen test, is the bifold card, and it can be used anywhere without pre-validation, making sure it's okay to use, in this site versus that site. And it's also requires very minimal training and no special equipment, most importantly. And therefore can be performed in various settings with minimal qualification. It is a clinical test. It is not a self-test, and it does require a healthcare professional or a designated staff individual wherever the test is being performed, who has to obtain the sample, which is a nasal swab. But once you obtain the swab, it's literally applying 6 drops of reagent. You fold the bifold card together and you get a result within about 15 minutes. There is some preliminary data coming out now suggesting that Binax Now antigen testing may be as reliable as in-laboratory PCR testing. So more information forthcoming on that front, and once we hear more, we'll share with everyone. Southwest District Health is now playing an important role for the entire state of Idaho, in that we Well, first of all, we are leading the way with active testing for COVID as a health department or as a health district. We're distributing, as Doug mentioned, Binax Now tests to other district partners, making sure that they can increase their testing capacity as well. And as well, we will be the first health district to conduct a validation exercise, comparing the Binax Now antigen test to the gold standard, which is in laboratory PCR testing, and that's going to be done at the state lab. We're going to look at how the results with Binax Now compare to in laboratory PCR testing for a number of tests as we scale up our Binax Now testing to make sure that there is concordance in results. They're similar with the antigen test, the Binax Now, and the in laboratory PCR. And IDHW is interested here to find out what we see, and we're also partnering with the state lab, obviously, who's in support of this validation exercise. The end goal of the validation exercise is to try and answer the question: when you have a negative test or a positive test with Binax Now, is there opportunity for us to do less confirmatory testing on PCR than what is recommended right now? So to increase testing capacity and decrease burden on the state lab and PCR testing. Other goals with the Binax Now testing includes we're creating a Southwest District Health Rapid Response Team to assist with testing and sample collection offsite as needed. As well, as I mentioned, and Doug mentioned, we're distributing tests to community partners. And eventually we'd like to offer testing in the satellite clinics. The focus, what populations are being tested, this remains first responders, law enforcement, long-term care facility staff, as well as students and teachers. And all individuals who are being tested need to demonstrate symptoms of consistent with possible COVID infection. Final, last point, just a quick update is Southwest District Health is collaborating with Northwestern Nazarene University to complete a demonstration project on wastewater analysis as a way to cost effectively monitor COVID-19 virus levels and infection trends specifically for congregate settings. And so this example is going to be a college campus and students living in dormitory setting. There is a possibility that we may expand this demonstration project to include a public school. There's been some preliminary conversations with Marsing School District on that front. That'd be very exciting. The purpose of this demonstration project is to see if monitoring wastewater and the levels of coronavirus in the wastewater, you can actually quantify it and follow trends up as well as follow trends down and compare it to your usual testing, as well as any mitigation efforts that are ongoing after a case is identified in these congregate settings. And then report back and see if this also could be a cost-effective solution for ongoing monitoring of COVID-19 in these various congregate settings. So that's just being initiated this week, and I'll certainly report back as we learn more and start to collect data.
Why, Clay, this is Sam. Why Marsing?
We've got obviously a good relationship established with Marsing now with the school-based clinic, and we just thought to reach out to them and see what their interest was, and they were quite interested. Their administrator was out last week, so we had a single preliminary conversation, and then we're due to I'm due to catch back up with him this week to see where they're at. Other than already having a relationship between the health department and that school district, they had their facilities person on a Zoom call 2 weeks ago, and he shared that those three, the elementary, the middle, and the high school are all on a single campus. And the facilities guy described that they're basically have two main outflow points, one that services elementary and middle, and I'm sorry, I believe this is correct. Elementary and middle is a single outflow, and then the high school is a single outflow. So literally they could participate by pulling samples from two manholes, essentially. We did talk about additional schools, which we don't have a pre-existing relationship with for other services. But just with it's a relatively short demonstration project. We're knocking around the idea of somewhere between 11 and 12 weeks, where we would sample on a weekly basis. And we just thought to talk to Marsing first because, we already know who to talk to, and they were quite interested. So obviously, if this looks like something that's has potential to be useful and cost effective for ongoing monitoring and surveillance of COVID in school settings, this could be expanded to other schools, Sam.
Right. The only reason I ask is Owyhee County's in the gray zone. Why not pick somebody that's in the red or orange category?
Sure. Yeah. Great question. So one of the assumptions with the demonstration project is all wastewater samples will be positive. Even Owyhee or Marsing School District has had some cases, and it's less at this point in the pandemic that we're trying to identify new positive wastewater samples, whereas in the previous weeks they were negative. That approach to wastewater analysis was employed on many college campuses this summer prior to students coming back to campus. One of the very first examples of that was University of Nevada in Reno, and also Utah State University, so our neighbors. And they were able to identify, negative this week, negative the next week. Okay, now we have a positive, and it's outflow to this dormitory. Let's go in and test everyone. And then they were able to identify cases early and employ some measures to prevent additional transmission in those dormitory settings. The assumption at this point is that probably with rare exception or no exception, any wastewater analysis testing is going to be positive, and we're looking at the level of virus, which can be done. Let's say this is a school where they have already identified some cases and they've implemented some mitigation efforts. You would expect that level to go down over time. So you're confirming that the mitigation efforts are working, as well as if you see it to start to trend back up, that would be an early signal that you need to look more closely and do some individual testing because there could be a reintroduction of coronavirus into the community that sample represents, that pooled sample.
Okay, thank you.
You're welcome.
Anything else? Any other questions for Dr. Roscoe? Okay, is that all you have for us, sir?
That's end of report. Thank you.
Okay, thank you very much. Appreciate it. Okay, we're already way past our break now.
My letter's about to break.
Yeah, I got to add to the outflow.
Okay, we'll take a short break. That is very, I already know what's there.
Ashley, can you hear us?
Yes, coming through loud and clear.
Thank you.
Very good. In that case, we are at the COVID-19 health alert level update for our district.
So hopefully, I think Rachel's joining us remote and provide us an update. She's on.
Rachel, are you there?
Hello.
Or muted?
Hi, can you hear me?
Yes, we can.
Great. Okay. So I'll just get started with a response to some of those questions that were posed earlier. I'm going to go over some of the common exposure sources that we've seen, and I will review hospital capacity a little bit later in the presentation. So I recently did a joint analysis with Central District Health and Southwest District Health data on reported exposure sources. And just to clarify, this is data we're collecting through our investigations. So it's not necessarily exhaustive, just what people are reporting to us. So our most frequent is household exposure, which I think is typically pretty obvious. And this is occurring across all different kinds of household settings, but especially in congregate settings. So our assisted living facilities, prisons, college dorms, and shelters. Our second most common exposure source is travel, and we're primarily seeing a lot of local travel. And I think that's just more due to access and frequency. We're seeing a lot of people going to vacation towns and mountain towns and reporting exposure occurring there. Our third most frequent exposure source is community events. And so we're seeing this in sporting events, religious events, fairs, rodeos, things like that with large groups of people, typically with strangers and the public. And then our fourth most common is our social events. So that's parties, gatherings, weddings, things where you tend to know more people and you're mingling a little bit more with larger groups of people. So that's just hopefully answered your question on the different exposure sources that we're seeing. Next, I'll look at some of our health alert levels, and we'll just kind of review that. So quickly, I'll just let you know where all of our counties are standing currently. Payette is in the red category. We have Canyon County and Washington County in the orange category. Owyhee County and Gem County are in the yellow category, and Adams is in the gray category. And just to let you know, we will be reviewing these this afternoon, and we'll have an update for you all tomorrow. And so we've seen Canyon County and Payette County have kind of remained at these higher categories for some time. And we're seeing slight increases in some of the key metrics that we're looking at. And we're really just hoping to see more of a downward trend before we do much movement between the levels. We have noticed that many of our metrics are kind of plateauing right now. And unfortunately, they're a bit higher than we would like to see. A few examples are our positivity rates and incidence rates. On a district level, right now, our positivity rate is at 9.34%, which is nearly double our goal. We want to see a positivity rate of 5% or lower. And then we're also seeing our incidence rates are increasing just a little bit, but they're really remaining pretty steady over the past few months, which unfortunately they're steadily higher than we'd like to see. So we're just really hoping to see more of a downward trend there, and then maybe remain steady at that point. And then so onto hospitalizations. So we are seeing an increase in hospital. Yes.
Before you go on to that, can I ask a question about the positivity rate? I guess my question is that rate higher because we're only testing people with symptoms?
I think that's definitely a factor. I know we are starting to get more robust testing, especially with the antigen testing and the rapid tests available or becoming available. But that's definitely a factor when we have only symptomatic patients that are able to be tested. And I know that in most of our counties, that's not always the case. There are facilities that are testing symptomatic or not, but some of our larger hospital facilities are only testing symptomatic patients. Did that answer your question?
Yes, thank you.
Okay. So next we'll look at hospitalizations. So as we mentioned earlier, we have seen an increase in hospitalizations across Idaho, and we are also seeing that in our district. Some of our hospitals here are at capacity right now. Obviously, not all of these beds are filled with COVID patients, but it is concerning because that means less resources if we do potentially see a surge in COVID cases. Currently, on a district level, so this is all of our hospitals combined, we're seeing about a 70% occupancy in our ICU beds. About 17% is for COVID patients. And then we're seeing about 60% occupancy for our inpatient beds, with 10% being for COVID patients. And then we definitely have some hospitals that are at 90 to 100% capacity. So that is a cause for concern. This is especially concerning when we think of flu season and some of the upcoming holidays that are, celebrated in a pretty social manner. We've been making really great progress over the past few months with slowing the spread of the virus and just urging everyone to stay vigilant and consider some safer ways to celebrate this year. So as for our determination system, we haven't added or removed any metrics to our health alert levels, but there are some metrics that we're holding more weight than they previously did. An example of this would be our educators input section and just information on COVID-19 within our schools. Most of our schools are operating in some capacity in person. And unfortunately, we're also seeing some cluster outbreaks occurring from that within our schools. And we're just really seeing this is very reflective of what's happening in the community. So the schools are very, very in line with what we're seeing in the community. And a lot of that is because, we're seeing infection or transmission occurring within a household and then moving into the school and vice versa. And thankfully, our schools have implemented some quarantine and isolation measures that are really helping to curb the spread within the schools and helping to stop that transmission from household to the school. And I know this can be really stressful and difficult on the students and the parents and the staff. And so I just want to say thanks for, we really appreciate your effort on keeping our families safe. And then lastly, I just wanted to mention that we have received approval to report COVID cases among students and staff grouped by school district instead of county. So we have updated that. So you'll start to see that data accompanying our health alert levels on our weekly news release. So I guess I will now open up for questions if you guys have any questions on the health alert levels or anything that I discussed today.
Any questions, commissioners?
I think, and this is kind of with this, but, I've been thinking about the vaccine and herd immunity and whatnot, and I frankly am not convinced we're going to have herd immunity because right now it's appearing that even if you get this illness or the vaccine, your immunity only lasts 90 days. And so it in fact may be impossible to get herd immunity. The other comment is, and I hope I'm right in this statement, I think we may have a better than average flu season because we're already socially distancing. And I hope I'm right on that.
We all do.
We hope so too.
Any other comments or questions?
Questions. We just heard, or maybe I misunderstood it, but didn't you just say that about 17% of the patients in the hospitals are COVID related? ICU?
Yes, 17% of our ICU beds are being occupied by COVID patients.
Okay, and then the other beds, what percentage of that is COVID related?
So for our inpatient beds, it's 10% are COVID patients.
But I do think, and correct me if I'm wrong, but when the governor gave his talk yesterday and Luke's talked, their numbers were much higher.
System-wide, I think that's true. I think Rachel is just reporting for hospitals in our district.
Right, I know but that's my point, is I think If you go to Luke, downtown Luke's,
Oh, I know they were,
that
that
number
was
is much
Twin
higher.
Falls. The guy that was there was, or it was Twin Falls.
We're talking about Boise.
Yeah, and I think they're diverting, and I don't know if it's just COVID patients or other patients too, from the Magic Valley to the Treasure Valley.
A lot of pediatrics, because they've moved the pediatrics ward to a COVID ward. And so anything pediatric comes to Boise.
Anything else?
Well, we've always wanted to stay away from this, but, you know, generally speaking, this is where they always end up. When you have healthcare system issues that are worldwide.
How do you mean, Kelly?
Yeah, well, when you have worldwide health, a crisis or whatever you want to call this, pandemic.
Yeah.
Okay. When you have it worldwide, you generally always end up with overfilling the hospitals, and you started the triage. It's been that way in history. You just go back in history, and it proves that. Yes, our medicine's much better than it was 100 years ago, but we're still not perfect. We still it takes us years to find vaccines. So, you know, and you just said that 90 days on the immunity, and then there was a report out just a month ago that said that at 6 months there was no absolute, and that came from the medical field, absolutely no drop in antibodies in the system. So there's a conflict right there. Wow. Now we're doing 90 days, and a month ago it was 6 months that you had antibodies, that the same amount of antibodies. So we're not getting all the full truth, and then that's just a fact.
I think you're confusing the truth with different studies. And so sometimes you come up with different answers. This is a very fluid issue, and, you know, what we say today is not going to be but it's the best information we have at this point in time.
But that is what is driving the freaking fear here. Instead of just saying, being consistent with it, oh, we got to change, because a month ago, your antibodies are good at 6 months. Same amount of antibodies as that you had it now. Now you just said, well, this latest study says it's not any good for 90 days.
Well, a month ago, I read 3 months.
I was just on a webinar call last night that said just exactly what you said.
Yeah. So, I mean, and that was from the medical field. I don't believe everything comes from the medical field, because they've, in the past, lied to us immensely. I mean, they shoved margarine down our throats. They shoved all this processed food down our throats, telling us it was the greatest thing since sliced cheese. And then now my grandparents, I watched them die because, well, they were going to die anyway. But but I mean, they had to give up all the foods they really liked because the medical field lied to them, and the government lied to them. And so I just
that wasn't a lie. That was the best information at the time.
Yes, it was a lie, because we had the science that proved it was a lie.
So Kelly, when you have a heart attack, we're going to treat you like we did in 1970. We're going to put you in bed. We're going to give you IVs. We're going to give you oxygen, and we're going to give you morphine.
If I'm going to die, I'm going to die.
Yeah, but healthcare has gotten dramatically better. And, you know, we can only deal with the best information we have at the time. And the information changes.
The other thing I want to say here is that this virus is different than other viruses we've dealt with, because the symptoms that are displayed by people with the same virus are so diverse. It's difficult to say, if you get COVID-19, this is what you're going to have, because it's across the board with different people and different blood types we're finding. Different blood types respond differently, and so it's really difficult. I don't think anybody's lying to anybody, but I think it's difficult to say, well, you're going to have 90 days of immunity, or you're going to have 6 months. Some people will have 6 months. Some people will have a year, but other people, I know of a couple of people that had it, positive test, they recovered, and then about a month and a half later, they had it again. That's not even 90 days. And so nobody's lying, I don't think, intentionally trying to create some sort of overriding message. It's just that the diversity of how people respond to this is making it difficult to say, this is what's gonna happen to you.
What would be helpful is if we had, because all we're getting is, you know, information that just comes from government. It would be helpful if we could have, an outside physician that's outside of the government come in, which is what we kind of talked about clear back in July, that was kind of mentioned, and it never happened. So, I mean, it would be helpful to at least have a lot of information so we could have a more balanced approach to everything we do. So,
Yeah.
exactly.
Well, Rachel, we took away part of your thunder. We're sorry. Apologize.
No worries. Thank you all.
Are you finished? Did you give us all your information?
I did. Thank you.
All right. I didn't want to cut you off or minimize what you're trying to report to us. So thank you very much for that report, if that's all. Does anybody else have any questions?
No. Thank you.
Okay.
Thanks, everyone.
Okay, thank you.
Thank you,
We'll go
Rachel.
with Nikki here.
Well, I was just going to say that that is an action item. Again, the board had asked that they vote every month on basically approving our methodology moving forward with the health alert levels.
All right. It is listed as an action item. I missed that. Okay,
I move we accept.
okay. I have a motion and a second. All in favor that we accept the way that we are, what's the right terminology?
Determining health alert levels.
There you go, that. All in favor of that motion, say aye.
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 Nay.
Okay, motion does carry. Note that there is a nay. Okay, Nikki, continue, please.
Thank you. I think these directors' reports will be brief. I'll start with the added agenda item. The Executive Council, which Commissioner Dale represents the board on, has a scheduled meeting on Thursday afternoon to talk about the upcoming legislative session. So I just wanted to make you aware that that is scheduled to happen this week.
2 o'clock.
Yes, sir.
Yep.
I also wanted to provide you with an update on our audit. We have a brief summary that was in the packet that was emailed out, and it's in the packet as well, that Zweigart, I think I said that right, has finished their on-site portion of the audit. They're still reviewing some documents, and they are actually going to meet with a couple of our staff regarding one of the past findings that they, when they were on site. I think it was maybe just oversight on their part or something, but they have a meeting, I know, this week with Troy and one of our other employees to talk about. But I think the good news is, of the 4 findings we had from the last audit, again, those are findings that are left over, I guess, from our previous financial managers prior to Patty, where we had a couple in place for consecutive years that weren't maybe, well, the right person for the job. So, but the good news is Patty did a great job addressing those and getting them rectified, and Troy has also really jumped on making sure our policies and protocols are in place and that we're following those. So we're hoping that all 4 of those will be resolved. Like I said, one of those is still being reviewed and should be wrapped up this week. You'll see in the 1-page brief memo that we have, they reviewed 60 WIC recipient files and noted 1 error. In the review of those, they felt that that was not a systemic issue and really an isolated event, so they are not considering that a finding. And then they provided Troy some feedback around how we establish direct cost allocation, and again, not a finding, but more of a best practice that we look at, that they offered and that we will probably adopt, which if you have questions about that topic, Troy could probably answer. But I wanted just to give you an update on where we are with our audit. Zweigart feels pretty confident that they can get us the final report before the end of the calendar year, which would be great. The Legislative Services Office was hoping to have that in hand before the end of the year so that the legislature would have it in the new session next year. And the last item I wanted to talk about is this public health symposium that we've done, I think, the last 2 years. We're planning to do it this year. We're trying to figure out a space. We're looking to see if the Nampa Civic Center is open so it can accommodate maybe some more attendees. So next month is also aligned with our board meeting. So we'd have our board meeting, and then immediately following that, elected officials symposium. And if we're able to get that facility, that's where our board meeting will be. So I'll let you know if we have a change in venue before then. And that's the end of my director's report.
Have you reached out to see how many would be coming?
Katrina has been working on that. I don't know if we've asked for RSVPs yet, but I did talk to a few legislators that I just kind of floated the idea by them to see if we should even have it this year. And I got positive feedback from them that they topic likely on the agenda of the legislature.
Is that going to be on the 17th, maybe?
Yes, ma'am.
And the board meeting is the same, okay?
Yes. Try and ease your travel time for some of you. Try to align it on the same day. So that's all I have on the director's report, and then we have executive sessions scheduled.
Okay. In that case, we need to go into executive session, and to do that, it is just board members. So, meeting's not totally over, but the part where you folks can stay. So, but thank you for your participation. Thank you for your concern. And we will, in a minute, we'll go into executive session. Okay, thanks.
Of people waiting. There's never been anything like this. I will say that. With being very humble, I'll say that, Jeff. Is that okay? But there's never been anything like it. We have tremendous crowds. You saw the lines. They formed 2 days ago. So we're going to make 2 stops. And you're going to be with us a little bit. And I know you're going to be with us a little bit. And we have a very exciting election coming up. We're doing very well in North Carolina. Very well in Florida, very well. Pretty much everywhere we're looking, we're doing very well. And when people find out really what we've done and how good the economy is and how it's coming back, the numbers are fantastic. So we seem to be in very good shape. Any questions?
Can you give us the latest on stimulus talks? What stimulus talks?
Yeah, we're having talks today. We're discussing it today very solidly. We'll see what happens.
Have you talked with Leader McConnell?
Nancy Pelosi at this moment does not want to do anything that's going to affect the election. and I think it will affect the election negatively for her. So we'll see what happens, but there are talks going on as we speak.
Have you talked with Leader McConnell?
I don't want to comment on that. But the Republicans will come along.
President, why did you criticize Dr. Fauci? Does it have anything to do with his high standing in public sentiment?
No, I think really Dr. Fauci's a very nice man, but we let him do what he wants to do. He gets a lot of television. He loves being on television, and we let him do it. Sometimes he says things that are a little bit off, and they get built up, unfortunately, but he's a nice guy. I like him, but he's called a lot of bad calls. He said, don't wear a mask, and he said, don't ban China. They were bad calls. He admits that, and I don't hold that against him. If I did, I wouldn't have him. No, I think he's a nice guy. Huh? I don't want to. I don't want to hurt him. He's been there for about 350 years. I don't want to hurt him. Well, they used to say, don't wear a mask. So, you know, you have people on both sides of it. But I'm okay, excuse me, I'm okay with masks. I like it. I think it's good. A lot of people like it. This gentleman has done an incredible job in Arizona, and he's taken a very tough stand, but he's let his economy grow. And frankly, if they would have done that in Michigan and various other places where the governors just shut it down for everybody except for a husband, his attitude, you know, they had a spike, and he let the spike play, and they were careful, and now your state is really in great shape.
Thank you, Mr. President.
What a job.
Thank you.
So proud of
Your
you.
chief of staff said today that there'll be a lawsuit filed on Section 230 on the tech company.
Who said that? Who said that?
Mark Meadows.